Yeah, okay. Thank you so much, Dr. Amit, for the opportunity. And I think it's going to be an excellent instruction course covering so many diagnostic tools. So, without wasting much time, I'll come to my talk. It's a huge topic. So, mainly, I'll restrict myself to mainly to the keratoconus diagnosis and follow-up of keratoconus. If time permits, I will go on to uh, other uh, uh, other indications. It's not moving forward. Okay, all right now. So I have no I have financial interest in the subject matter of this talk. As you all know, there are so many instruments available in the market which gives us tomography, but today I'll be emphasizing only on Pentacam. And these are the various clinical uses of Pentacam, and I will be emphasizing mainly screening for the reflective surgery. And if time permits, so we will little bit talk about post-refractive surgery R calculation, as well as the role of Pentacam in choosing aspheric and toric IOLs. So coming to the screening for the keratoconus, as we know, what all things one has to look for in the Pentacam is most important is the anterior elevation map, and in this map, values of less than 12 micron are usually considered normal, and more than 15
100
micron in the central 5 millimeter are typically
seconds.
above. Yes,
जनकपुरी में सर C2/390 है पंखा रोड पे वहाँ पे
you can hear me now. Okay. Yeah, similar number about 5 micron hard in the posterior map, elevation map are more sort of suggestive of keratoconus. And these values are significant only if present in central or paracentral area and in a localized pattern. High plus value may be seen in periphery because of astigmatism and do not denote any abnormality. This is the right eye elevation, front and back elevation of a patient. You can see the elevation of 27 micron and 53 micron on the back elevation, and uh, I mean, significant. And this is the anterior elevation map. You can see that corneal thickness is just 418, and the K value is to the tune of almost 50 diopter. So these are the advanced cases of keratoconus, and this is elevation is not always in the form of island. It could be a tongue shape, which is called a peninsula. As the keratoconus advances, it breaks off from the periphery and it forms into a island. So it can arrive from both the sides in the form of a bridge pattern. And this is the anterior elevation map showing high K rating as well as very thin cornea in a case of advanced keratoconus. But this is another case. Patient came to us with the -2 diopter of refractive error with no cylinder, and there was pachymetry of 560 micron. As you can see, there is a slight asymmetry of both eye. Thickness is okay. Elevation is to the tune of back elevation, slightly on the higher side, but within the normal limit. So what to do in these cases? And this is the right eye of the same patient where there is a frank keratoconus, as is evident from the K reading, posterior elevation, anterior, posterior, and the the thickening. So in these cases, maybe doing a Balin-Ambrosio enhanced ectasia, looking at this map and looking at comprehensive spectrometry map, more item of this thing. So this is the reflective map of the same patient showing borderline features of keratocornea is thin. There is a little tongue-shaped elevation in the back of the cornea. What Bellin and Bozio map does is uh, it exclude an area of 3.5 millimeter around the apex, and it charts it calculates a base curve, reference base curve, excluding that area. What it does is creating a new reference sphere has a minimal effect on the normal cornea as you see in the below picture, but it greatly enhances the ectatic area of an irregular cornea as seen in this figure. So looking at the Bellin-Ambrosio ectasia map, it gives you a elevation, enhanced elevation, which is so important in early cases of keratoconus and which may be masked on the anterior surface by the epithelial thinning. So sensitivity for screening of keratoconus suspect or firm fused keratoconus is increased by looking at this map. So again, okay, and what all to look for in this Galen approach is okay. We have to look for these five values of these are again just statistical variation of thickness, back elevation, pachymetric progression, thickness, and displacement of thickness point and artmax index. But individually, these values are not that important as compared to the value, which is a combination of all these values. So if it is more than 2.6 standard deviation, it becomes a diagnostic for keratoconus. So it is a very important map to look for in case of suspect keratoconus. Here you can see it is 11.6, far beyond. This is about case of keratoconus, but in subtle cases, if it is around more than 2.6, it is definitely. And if it is between 1.6 or 2.6, it is said to be, one can wait and watch the case, look for the family history, or look carefully in the other eye. And what about the staging? This is the ABC staging. This is a one map which is tells about the topometric or keratoconus staging. Depending upon all the indices, here you can see the this is a right eye map with the high K rating, asymmetric bow tie, and these is the anterior curvature, posterior curvature, corneal thickness reading in form of a map, and this is a keratoconus grade 2 depending upon the severity of the disease. And this is just to highlight this how we can classify the keratoconus based on this ABCD map in the keratoconus. And in this case, it was grade 4, depending because of the anterior posterior curvature and the corneal thickness less than 300. And one can, it is very important to follow up a case of keratoconus suspect. This is a very busy slide. So this is a right and left eye of the same patient. And here we can see there is a hardly any progression in the K readings. And if we see the other eye, there is a gradual progression of the disease in terms of keratometry as well as KMX. And here we planned C3R. So so the pentacam is very important for following up the cases of refractive, post-refractive surgery or case of keratoconus to see whether the disease is progressing or not. And this is just a, bar map of same thing shown in a graphical manner. So I'll skip that. And then coming to the comprehensive pachymetric evaluation strategy map, what it tells us is that it defines the rate of change between the central and the peripheral part of the cornea. And this is a normal map. And these two dotted line tells us the two standard deviation below and above the normal. If the line falls beyond this, then it has become a sort of a diagnostic for, like in this case, we have this line falling outside the normal range. So it is abnormal. Anything more than 1.2, this thing is taken as abnormal. Then in holiday report, nothing else is but it is just it shows us best toric fit ellipsoid elevation on tangential curvature. And if you see hotspot posterior elevation as well as thinnest pachymetry at the same point, that becomes diagnostic for keratoconus. And this is a one case of just I'll show this case, then I'll stop because it is too short a time to describe all the features of tomography of pentagram in this one small talk. So how to see? This is a case who presented to us with high K reading, and the keratoconus indices say, okay, because the K reading is this, I think these are the normal values for final, like D value I have talked about, the elevation at the thinnest point, and Artmax less than 340 is abnormal. So all these points I have discussed. Other indications like calculation of IL power or role in the toric IL lens selection, I think we can discuss at some other point because of the shortage of time. Dr. Amit, you take over.